So in chapter 25, our last chapter of our newborn series, this talks about situations in which newborns are high risk, requiring more monitoring and potentially more interventions. So when we're talking about a high risk newborn, all that means is there is something going on that increases their risk of morbidity or mortality. Um, up through 28 days of life. So a neonate is classified as a baby up through 28 days. Yes, they're still an infant. Infants are birth to 12 months, but in that first 28 days, they also have that additional classification as a neonate. After that 28 days, they're just referred to as an infant. And the reason that 28 days is different is because they do have an increased risk of morbidity and mortality in that first month. More so than your older infants, especially if you have a high risk infant. So there's various different types of classifications. These are discussed on page 638. This could be based on their birth weight. So if they're intrauterine growth restriction, like we talked about, mothers who use cocaine, tobacco, methamphetamines, things like that, it could be that they're very small. The low birth weight or very low birth weight, large for gestational age or small for gestational age. So large for gestational age, like the macrosomia babies that are born to your diabetic mothers, that could be put them at higher risk of various different things. Their gestational age, preterm versus post-term. So preterm, before that 37 weeks, increases the risk. The earlier they are, the higher the risks are. They do have late preterm and early preterm. So your late preterm is generally your 34 to 36 weeks. They usually don't have high risks, but it's still risky, especially when you're talking about things like hypothermia and respiratory distress. But the earlier they are, the more risk they're going to have. And then post term, because that placenta starts to wear out and it's not oxygenating baby as well, that can lead to problems as well. So when we're talking about high risk care, all it is additional interventions above and beyond what you would do for your normal newborn. Oftentimes more frequent and detailed assessments. One reason people are often scared of children, especially infants, is because they're very good at accommodating what's going on. So their body, they'll look pretty good for a while. They'll just have subtle changes and then they crash a lot faster. So monitoring them frequently, assessing them frequently, and looking for those very subtle changes. They're not often going to be drastic changes until it's really too late. Providing respiratory support if needed. That could be just something simple as a nasal cannula all the way up to being intubated. Thermoregulation is even more important in your preterm babies. They have a much higher risk of hypothermia, and really their hypothalamus is very immature and they cannot regulate their temperature. So you will see in all infants, but especially your high risk infants, instead of getting a fever when they have an infection, they may drop their temperature, or their temperature may be unstable, like bouncing back and forth, just as significant as a fever. Their hypothalamus just doesn't know what to do. It knows it needs to do something. There's an infection going on, but it doesn't know what. So just like in the elderly, a lot of times with infants, you'll see their temperature actually decrease or be irregular as opposed to a fever. They are at higher risk of infection with preterm babies, especially. So even more infection control measures. They will, in your very early preterm, they'll put them in an incubator where it's completely closed in. That way, it's almost like airborne precautions for them, so they are not exposed to all the external air. They may need additional feedings. Oftentimes in preterm babies, their suck is very weak. So even if they're feeding enough as far as frequency, they may not be getting enough because their suck is weak. So oftentimes what they will do is they will give them a bottle and give them a set time to eat, usually 20 minutes, maybe 30 minutes. And then whatever they don't eat from the bottle, they get through an NG tube. So that way they're not completely giving them NG feeds. They're still stimulating that suck reflex and hopefully building that sucking strength. But they're not just letting them eat forever, because then that doesn't help build those needs. It doesn't have to be formula. They oftentimes will have women who will pump breast milk, and then they can give breast milk through the NG tube as well. So birth injuries. Your ATI book does a really good job of listing various birth injuries and congenital defects. I highly recommend you read them all. There's a little blurb about each one. You will probably see those again. So there are various different things that can happen either in utero or during labor and delivery, or even immediately after. Skeletal injuries are fairly common, especially clavicle fractures. You can have nerve injuries like that brachial plexus injury if they get stuck on that pubic bone, that shoulder dystocia, and it pulls on those nerves in the neck. You can get cerebral palsy. Cerebral palsy is not genetic. Cerebral palsy is caused by some kind of insult to the brain. Most commonly, and sometimes it's trauma. Oftentimes though, it's hypoxia. So you'll hear it called an anoxic brain injury, and that means the tissue was injured because it wasn't getting any oxygen or not enough oxygen. So one of the most common causes of cerebral palsy is that anoxic brain injury, and this is an injury to the brain. It is not genetic. So something happened to cause it. So it's permanent, lifelong. Not always progressive, and it varies in severity from patient to patient. You have patients that are completely bedbound with cerebral palsy, and you have patients that can ambulate and talk and everything. So it just varies. The one that's listed here under neurological injuries that's not really it may not be an injury, is hydrocephalus. So hydrocephalus can be from an injury. You'll see it sometimes with cerebral palsy, but it sometimes is congenital. So hydrocephalus literally translates to waterhead. And this is where their ventricles in their head, which is where all your cerebrospinal fluid absorbs and gets reabsorbed and pulled back into your body. The ventricles are not draining that fluid like it's supposed to. There may be something blocking it. Or otherwise the ventricles just aren't large enough or whatever it be. So they will start having potentially seizures, neurological dysfunction, things like that. So monitoring for those symptoms, because a lot of times it doesn't get caught until maybe they're evaluated for seizures. Neonatal infections. I already mentioned how sepsis is a big deal in babies because it can progress so rapidly. Page 642, it discusses the risk factors of developing neonatal sepsis, as well as the symptoms you may see. Some of the risk factors: no prenatal care is a big one. If mom had GBS or group beta strep, if mom had substance abuse, if mom had premature rupture of membranes, meaning her membranes ruptured before she went into labor, especially if it was more than 24 hours from the time her membranes ruptured until she gave birth, that increases that risk of a neonatal infection. If there was a meconium aspiration, meaning there was meconium in the amniotic fluid and baby inhaled some of that when they took their first breath, that can lead to a pretty significant pneumonia. So various different things can increase the risk of sepsis. Sepsis is serious in infants because they don't really have a mature immune system. So even though they're kicking out those white blood cells, and even though their numbers may be high, a lot of times they're very immature white blood cells. Their bone marrow has not specialized enough to put out the types of white blood cells that are needed. So it's not able to fight the infection as readily as somebody who's older. Like I mentioned, all infants under the age of 6 weeks automatically get admitted if they have a temp of 100.4 or higher rectal. It's automatic. They will do full cultures. They will do blood cultures, urine cultures. They will do a spinal tap to do CSF cultures, because they want to make sure they don't have a more serious infection. Sometimes it's just where they're monitored until those cultures come back and then they're discharged, but they can progress so rapidly with sepsis. So Torch infections are one of those things. We've talked about torch infections. These are infections that if mom is exposed to it, or even baby, so it doesn't even have to be mom during pregnancy, but if babies are exposed to, say, rubella, especially in that first month, they can have permanent neurological defects from it. Um, and because they haven't had that immunization yet, hopefully they got some of that protection from mom because she already had antibodies. But if she didn't, that can increase their risk because they don't get rubella yet, the rubella vaccine. So on page 645 to 648, it discusses very specific infections as well as the nursing considerations. So a lot of it is going to be monitoring for symptoms. Symptoms are not always obvious. So temperature instability is a big one. Again, it's not always where their temperature is going to go up. It may go down or it may just bounce back and forth. Oftentimes they may be fussy to begin with and then lethargic. So they could be fussy or lethargic. They may have a low muscle tone, be kind of floppy, hypotonia. They may not feed very well. So they may be very difficult to arouse. So if parents are having trouble arousing them for longer than an hour, they need to be seen because that could be a problem. They may start having respiratory symptoms such as tachypnea or things like that. So drug exposed infants. We've talked about this a little bit when we did pregnancy, but neonatal abstinence syndrome is what we mostly think of, and this is where they are withdrawing from your narcotics. So symptoms of neonatal withdrawal include things like the high pitched, irritable, whiny type cry. They typically don't feed very well. They're very fussy, irritable, difficult to soothe. Some other symptoms you might see that you wouldn't think of: excessive yawning, if they're yawning a lot, or if they're sneezing because the withdrawal causes nasal congestion. So they may be sneezing more so than you would typically see. And on the next page, we'll look at there's a neonatal abstinence scoring system that we use to help us determine that. So some other things: alcohol, cocaine, methamphetamines, they can have any exposure to these can result in temporary or even permanent complications, like alcohol, for instance. They can develop fetal alcohol syndrome, and that's not reversible. SSRIs are another big one. Most SSRIs cannot be taken during pregnancy. So if mom was taking those, baby can start to get serotonin syndrome or even get withdrawal from those SSRIs, have poor feeding, difficulty sleeping, things like that related to that withdrawal. So when we're talking about the neonatal abstinence scoring system, they will do these scores regularly to look at changes in baby's behavior. It can help them determine titration of drugs if they are using weaning medications like morphine or methadone to try and wean these babies. It can help determine the dosage, if they need to increase or decrease the dose, or even sometimes they will use that as a determinant whether to even put baby on those medications. If baby is really not tolerating their withdrawal, that may be change their mind to put them on that. This score is, or this withdrawal scale is shown on page 652, but this gives you an idea of some of those symptoms you may see. For instance, the problem sleeping, the high pitched cry, sweating. I mentioned before, babies don't sweat and babies don't shiver, except when there's a problem. So for instance, with neonatal abstinence withdrawal, they can have shivering and sweating. They can get a fever. So free sweating and sneezing. I'm sorry. Sweating and shivering can both be an indicator of abstinence withdrawal, where they'll have little tremors. You also see the tremors with hypoglycemia. So when babies are born to your macrosomic babies, high risk of hypoglycemia because of their pancreas functioning at mama's high blood glucose level. Now baby is born, doesn't have that high glucose, and their blood sugars can plummet. So you'll see where they'll get the tremors as well sometimes, and that can be a sign of low blood sugar. So speaking of infants of diabetic mothers, so this is a big topic because they are at risk. So the picture you see, the baby on the left is your normal size newborn. The baby on the right is your toddler or your macrosomic newborn. So macrosomia over 4,000 grams or 4 kilograms. So some of the biggest thing you worry about with these macrosomic babies is hypoglycemia, especially in the first 48 hours. They should be frequently monitored. If you have a baby that is macrosomic or born to a known diabetic, they are most of the time going to be your priority patient because they need to be frequently checked and monitored to make sure they are not dropping their blood sugar. So oftentimes they try to avoid oral um, glucose, just straight glucose, because glucose by itself creates a roller coaster ride. When you give just glucose, then they come up, they go down, they come up, they go down. But when you can give them something like formula or breast milk that also contains protein, that will help them stabilize their blood sugar a little bit better. If they are dangerously low, then yes, they will go ahead and give them glucose because you want to get them up quicker. It takes longer to process formula or breast milk, but it's better to give them something with more nutrition than just glucose to stabilize. So what is a normal newborn blood sugar? So in a full-term baby, it's 45. So it's significantly lower than your adult blood sugar. In a preterm baby, it can be as low as 35 and still not need treatment. So it just depends on their gestation, how low it can go, but definitely 45 is, there's not a lot of room to drop once you get down to 45. So that's why it's so important to watch them, because they could be at 20 in no time. So last thing we'll talk about spina bifida. We'll talk about this when we get to pediatrics as well. So with spina bifida, there's a group of disorders. This goes under neural tube defects. So neural tube defects can include anything from anencephaly, where they are born with a portion of their brain missing, all the way down to spina bifida, which is where they have a pouching of their spinal cord that is not fully well, it's encased, but it's not where it needs to be. So there's two kind of main types: occulta, which is hidden. So when you have occult blood in the stool, that's where you have hidden blood, and you test it on the card. So a spina bifida occulta, it's hidden. You can't see it. Usually you'll see something like, if you look at the bottom picture, the one all the way to your left, what it's showing in the picture is a tuft of hair. So sometimes you'll see along the spine, you'll see a tuft of hair along their sacrum, or they might have an extra dimple, and that can indicate that occulta. Typically, symptoms of the occulta is not as severe, or it could be a cystica, where you actually see the sac sitting on the outside of the body, and the potential for complications and long-term complications are usually much higher with that. So here's an example. If you look at the top picture, that's an example of that dimple, that extra dimple above the sacrum. These are usually more minor, may or may not need to be corrected depending on the severity, depending on what symptoms they have. This early on, you might not notice the symptoms as much because they're not moving around as much as they would be later. So it'll all depend on the severity, what they see. The most common symptoms of both types of spina bifida is urine and bowel problems. Pretty much everybody has some kind of urinary and or bowel problem. There was a girl I went to nursing school with. I had no idea that she had spina bifida until she told me. She walked normally, normal gait. And she said the only symptom she has is that she would get frequent urinary tract infections because of the urinary retention, because of the nerves not affecting her bladder as well as they should. And then your bottom picture is that cystica. So this is where you have that sac sitting on the outside. There is an increased risk of rupture of that sac. I mean, it's on the outside of the body. It's just enclosed by that meningeal covering. So it can rupture either during birth or after birth. And these are going to be corrected. They can now correct those in utero. They're doing this more. They started it this year, successfully being able to do this. And babies that can get it in utero sometimes have no permanent complications, which is fantastic. So when we're talking about nursing care of spina bifida cystica specifically, with occulta, there's nothing we as nurses are going to do extra because it's on the inside of the body. There's nothing that we're worried about on the outside. But if you have a cystica where you have on the outside of the body, they're going to go to surgery, but it's not an emergency surgery. So it may be a couple days before they correct it. They're going to be placed in an incubator prone positioning. You want them laying on their stomach at all times. Even when they're eating, they'll be in a prone or maybe side lying, but mostly prone position. They will keep a moist dressing, a sterile dressing over it to keep that sac moist, because as the sac dries out, it's going to crack and rupture. Keeping them protected from injury, keeping them protected from infection, and monitoring for infection. Things like that, lethargy, irritability, unstable temperatures, difficulty feeding, things like that, because that can indicate that they're getting an infection related to that spina bifida. So last little thing about preterm and late preterm infants, specifically some of the complications that you can have. Some of them are related to being preterm. Some of them are related to our treatment measures that cause it. Bronchopulmonary dysplasia, for instance, and retinopathy of prematurity. Both of those are caused by too much oxygen. So what happens is if we give them too much oxygen, we're not monitoring their SATs, and they're getting too much, then because their blood vessels are already small, oxygen causes constriction. So when you constrict those tiny little blood vessels in the eye, it cuts off blood supply to the retina, causing permanent blindness. With bronchopulmonary dysplasia, where they're getting so much oxygen, it actually causes scarring of the lung tissue, and they have permanent, almost asthma-like complications, and sometimes requiring them to get a tracheostomy. So making sure that we're very important in preterm infants, that we're monitoring their pulse oximetry. They don't need to be 100%. A lot of times they don't even want them to be 100%. They might only want them to be 95 or 96%, because you don't want to give them too much oxygen and cause those complications. They're also not traditionally kept on what you think of as your traditional ventilator. They're often put on what we call oscillators, where it takes little puffs of air into their lungs at a much higher rate. So the oscillator may run at 80 or 90 breaths per minute, but it's just little tiny puffs of air. So it's putting less pressure on those lung tissues. What you see in the picture right there is called necrotizing enterocolitis. You can get this at any age, but you think of babies with it. And the reason new preterm babies get it is if they don't have that bacteria in their gut when they start eating, then they can have it start to break down their gut, and it will cause necrosis. And the only treatment for this is to remove the affected bowel. And they'll give antibiotics for it as well. But if they are having abdominal distension, poor feeding, bilious vomiting, where it's the greenish yellow vomiting, that can be a sign of necrotizing enterocolitis. And it can lead to sepsis as well. So making sure you're monitoring for necrotizing enterocolitis. Another thing that we worry about that I already mentioned earlier was the surfactant. So surfactant is important with preterm babies. Oftentimes they haven't made it yet, or haven't made enough of it, so they may need to be intubated for respiratory support to get that surfactant in. You can put the surfactant directly down the endotracheal tube, and monitoring their progress with their pulse oximetry can let you know that the surfactant worked.